Good afternoon, ladies and gentlemen, dear colleagues. What I would like to do this afternoon is go through the step-by-step approach and highlight some items with some personal tips and tricks during the ACP implantation. And I think what's forgotten quite frequently is that you have to evaluate your patient before you send the patient to the cath lab. You have to measure the size of the left atrial appendage, and you have to evaluate whether this appendage is feasible to be closed, in this case with the ACP. You need to exclude thrombus. And personally, we prefer to do a TE the day before the procedure, just to exclude the thrombus, and also just to avoid discussions on the cath lab table when you find things like this in the left atrial appendage. If you do it the day before, you can discuss, and you can do a TEE with contrast, or send the patient to CT to be sure that there is no clot inside the left atrial appendage. Because until today, there are still a lot of procedures aborted in the cath lab because of the presence of a thrombus. One of the next steps is that you have to cross the intra-atrial septum. And I'm sure that some of you are not used to go through the septum. And one of the techniques is to use the SafeSept wire, which is a very thin wire, where you put the Brockenbrough needle against the intra-atrial septum, you push the very thin wire through the septum, and the wire immediately makes a small curve. So you are safe to push the Brockenbrough needle through the intra-atrial septum. We implemented this technique in patients who we treat for pulmonary hypertension and to create a fenestration, because then the left atrium is very small. And now in this case, when you are protected by the wire, you can really push the Brockenbrough needle into the left atrium. And again, if you go through the literature, you will find that there is a lot of pericardial effusion found as complication, and maybe this is one of the reasons why you might have pericardial effusion if you are not doing a safe puncture in the intra-atrial septum. In the next step is that if you puncture the septum, we prefer to go posteriorly and inferiorly because it will be necessary to have later an optimal alignment for the sheath when you want to advance the sheath into the left atrial appendage, as you can see here on these TE images. It is preferred, but I know some people does not, but it is preferred not to go through the PFO tunnel, especially a narrow PFO tunnel. This is an example where the sheath is going from 7 o'clock to 1 or 2 o'clock through a puncture. And you can see the alignment of the sheath when it goes through the intra-atrial septum. This is a patient where a catheter is going through the PFO with a very narrow tunnel, and you immediately see that there is an angle of almost 90 degrees, which will create some problems when you want to an optimal alignment of your sheath when you want to implant the ACP. And of course, from the moment that you're happy and that you are through the septum, do not forget to give the heparin in all your enthusiasm. One of the next steps is to make an angio in the left atrial appendage. And I come back to the problem of pericardial effusion. If you make angios, when you make it through the sheath, always protect the distal part of your sheath with a curved wire, as in this example. Or you make a sheath through an atraumatic pigtail catheter. Just to avoid these effusions, because safety of this procedure is a very important issue. In one of the next steps, you choose the optimal projection. And we know from the instructions for use that it is better to go to a cranial view, 30 degrees cranial view, aerial-cranial view, 30 degrees, 10 degrees, because then you can visualize quite optimally the ostium and the neck of the left atrial appendage. And again, good visualization is the best thing you have for an optimal procedure. The caudal view might help you to demonstrate more the body and the tip of the lobes, but as you can see here, an AP view or a lateral view or an LAO view will not help you a lot in visualizing the anatomical structure of the left atrial appendage. And then we create our own echo navigator. After we have done these angios in the left atrial appendage, we start to evaluate the landing zone, or to identify the landing zone and to measure the landing zone. As you know, for the ACP, it's 10 millimeters inside the orifice, and you have to realize that the ACP lobe has to be transverse or perpendicular to the axis of the neck of the left atrial appendage. And what we are doing is, and this is our echo navigator, is to draw a landing zone on the fluoroscopic screen. Because then you can already imagine where exactly the lobe has to be positioned. And we do the same for the ostium. You need measurements of the ostium, and you have to realize that the ostium is not really circular, and in most of the cases oval, which has been already discussed earlier this day. So do not undersize, and in most of the cases you have to oversize the largest diameter of the ostium to be sure that the ostium is covered by the disc of the left atrial appendage occluder. And again, we do not only draw the neck of the left atrial appendage, but also the ostium on the fluoroscopic screen, so that we have a kind of overlay in our imaging. After identifying and measuring the ostium and the neck of or the landing zone of the left atrial appendage, we have to go to the instructions for use to decide which kind of or which size of device we will use. And we look to the sizing chart, and of course it is important for the ACP to look at the lobe size. In general, we oversize about 2 to 4 millimeters, sometimes even 6 millimeters. But you might have discussions in the cath lab. Are you going to take a 22 or a 24? Sometimes you can also look at the ostium and the size of the disc to be sure that you will cover the ostium of the left atrial appendage. So it is important to look at the lobe size, but for some reason it is also important to look at the size of the disc of the device that you will implant. An example for this device, and sorry for these bad images, but this device before release seemed to be well implanted. There is a parallel orientation of the axis of the lobe and a parallel orientation with the axis of the disc. But unfortunately, and probably because of traction of the cable, when we released the device, the disc jumped behind the pulmonary vein ridge, as you can see here. And this is not what we like to see. And this is even better to see when you go to the 3D images, and I'm going to help to orientate you. So the device, and here you have the pulmonary vein ridge. And the device is behind the pulmonary vein ridge. So the disc is really pulled inside the left atrial appendage, and normally you will expect images like this. This we do not like. So probably if we had chosen a larger disc, a device with a larger disc, maybe this would not happen. So in the next step, when you have chosen your device, you have to load your device and you have to de-air your device. And it seems very obvious to de-air your device. And when you advance the device through the sheath, you must avoid that air is pushed into the body of the patient. So we allow back bleeding. And why do I want to focus on this part? Well, if you look to complications, 1 to 3% still experience air embolism. And this has nothing to do with the device. This has nothing to do with the procedure. This is completely the responsibility of the operator. So please de-air, and in my opinion, back bleeding is the best way to avoid pushing air inside. In the next step, you want to deploy the distal lobe. And first of all, you need to align the sheath with the axis of the neck. And in most of the cases, your sheath has to point at 1 o'clock or 2 o'clock in this direction. Then you open the lobe to a ball, and then you open the lobe completely. I think it is very important that you follow the same movements on TEE. As you can see, the lobe, where it is just a ball, and the lobe completely deployed. And in my opinion, you need both screens in front of you. there must be a simultaneous projection of endofluoroscopic images and the TEE images. Sometimes we experience cases where the echo machine is in the corner of the room, which is not what we would like to have. So this is important, and in most of the cases we deploy the device on fluoroscopic screen and we implant the device on TEE images. And then you can protect yourself to come into situations like this, where, for example, the lobe is implanted too deep. The lobe of the device is implanted too deep in the left atrial appendage. And of course, from the moment that you open the disc, you will create a small cavity which might be a kind of a predisposed region where you can develop thrombus formation. And there are some scarce data, but data that suggest that thrombus formation might happen here in situations like this. The disc is not covering the ostium. This is called the cul-de-sac. So, also, because the lobe is implanted too deep in the left atrial appendage, the disc is really pulled inside because of too much tension. So you can reposition the same device, as you can see here, and now the disc is clearly covering the ostium of the left atrial appendage. And because I grew up with TEE, these images are much easier to interpret on TEE instead of on fluoroscopy. But it is disputable, of course. When you open the proximal disc, you use the cupping technique, and you have to follow what you are doing. So you cup the ostium of the left atrial appendage, as you can see here. What you must avoid is that you push on the device, that you push the device further in, otherwise you may create a crescent-shaped lobe, and this might lead to unhooking of the wires into the left atrial wall. So just open the disc and that's all. Very important, after you have opened your disc, make an angio. And carefully look to the position of your disc, and for example in this patient you see that there are still trabeculae which are exposed to the lumen of the left atrium, which might predispose to the development of clot formation. And you might go to 3D images to evaluate exactly where the position of the disc is in this specific case. Of course, then you want to release the device, a very important step in the procedure, and you have to go through the five signs of stability. The first sign is orientation of the device lobe, which has to be consistent with the axis of the landing zone. And this seems to be a nice case, where the axis of the lobe is perpendicular to the axis of the neck. Situations like this must be avoided because this predisposes to embolization. And based on data on file, about 84% of embolizations are due to this kind of malalignment. To avoid this, correct puncture, inferior, posterior, optimal sheet curve, because you can choose sheets 90 degrees or 45 degrees. Personally, I prefer the 45 sheet. And then optimal sheet rotation up to 1 o'clock or 2 o'clock. Next important step is the lobe compressed? And in general, we expect to have a lobe which is tight-shaped. If the lobe is puck-shaped, probably it's undersized. When the lobe is like a strawberry, probably the device is oversized, although there might be other ideas about this. But in general, we accept this as being oversized. So these situations are unstable because the stabling wires are unengaged and the device may embolize. And the lobe is very easy to evaluate because you can see here on echo, in different angles, the lobe compression is easy to see on echocardiography and on fluoroscopy. Third sign of stability is that the disc must have a concave shape, and this indicates that the lobe is pulling the disc a little bit inside the ostium, as you can see here and as you can see on these images. and the disc must be separated from the lobe. Again, easy to see on echo and on fluoroscopy. And the final thing is that you have to be sure that the lobe is at least 2/3 beneath the level of the circumflex artery, as shown here. Again, because data on file showed that about 80% of embolization occurred because of the fact that the lobe was not 2/3 behind the circumflex artery. So you have really to follow these 5 signs of stability. And I just want to finish with one very easy case. So this is an appendage that we closed a few months ago. As you can see, the typical image, the areocranial, the areocaudal. The neck is better to see here in the areocranial. We did some TE images and we found that the landing zone was 24 millimeter. The ostium was 28 millimeter, short axis, long axis, so we decided to implant a device of 26 millimeter. And then we went to the 5 signs of stability. We looked at orientation, so the device seems to be well orientated to 1 o'clock or 2 o'clock. Device lobe compressed. I see here compression and I see here compression. And even on the echo, there are signs of compression. Concavity of the disc was confirmed by the 2 images. Maybe not extremely, but there is concavity. Disc separated from the lobe. And finally, position confirmed in relationship to the circumflex artery, which is located here. So the only thing what we have to say about this, this left atrial appendage is that the neck is quite short, as you can see. And that there is a very small, you can call it inferior ridge. I know that is not the optimal anatomical word, but you see that the lobe is sitting on this inferior ridge. So you can think maybe this is okay. But then we gently pulled, not vigorously, because device dislocation might also happen after vigorous pulling. And the lobe flipped over this inferior rim. So we needed to reposition the device, and now the lobe is sitting behind this, I can call it the inferior rim, and is now well fixed. And again, after repositioning, or also even after gently pulling, you have to go back again through the 5 signs of stability to be sure that you are not missing 1 or 2 components. So what I didn't show you in the beginning is the angio immediately after the first attempt implantation of the device. And you can see that the disc is not touching the wall of the left atrium in the inferior part, as you can see here. After repositioning, there is a small change in the axis of the device, and now the disc is really touching the wall at the level of the pulmonary vein ridge and also more inferiorly, and this is the correct position that you need to achieve. Again, therefore, we have very carefully to look at the angiogram, and angiograms like this with a not optimal view, they are really useless. So you cannot evaluate. You have to do angiograms when you look at the device in this angle visualized. So to conclude, I think that when you use a very systematic step-by-step approach and you do not forget items during this implantation process, and in some items you use some tips and tricks, the balance of benefit of LAA closure versus oral anticoagulants will be undoubtedly positive. Thank you very much.